Health Alert is brought to you by OU Physicians in Tulsa. Hello, welcome to Health Alert. I'm Pam Butler. Today we're going to talk about Crohn's disease, and joining me is Dr. John Fucci, a gastroenterologist and hepatologist, right?
That's correct.
And you're also an associate professor at the University of Oklahoma School of Community Medicine, and you work with St. John's Sapulpa.
That's correct.
Welcome, welcome.
Thank you.
Now tell our viewers, before we get into Crohn's disease, exactly what is a gastroenterologist and hepatologist? I mean, what do you do?
A gastroenterologist specializes in diseases of the digestive organ.
Okay.
So it starts with the esophagus, the feeding tube, the stomach, the small intestine, the colon, and also the pancreas and the liver, which are digestive organs.
Okay. Okay. Now with these particular, give people an idea of when they should think about seeing a gastroenterologist. Let's say if I'm having some difficulty swallowing for some reason, or pain swallowing, or things like that, I should go to look at a gastroenterologist compared to just a general internal medicine or a family practitioner, or how should we look at this?
Well, you may want to start off with your family practitioner or your internist who would refer you to a gastroenterologist, but generally a gastroenterologist, the common things we see are problem swallowing, which is called dysphagia, abdominal pain, gastroesophageal reflux disease, heartburn, diarrhea, any type of abnormality in liver function or pancreatic function are the main things we see. But I'd say the most common complaint we see in the gastrointestinal clinic is probably abdominal pain, and then changes in bowel habits and problem swallowing and heartburn and things like that. The other thing we do is screen people for colon cancer.
That's what I was going to ask. Is that a big part of what you do too?
Yeah, one of the main things we do is colonoscopy, and it's currently recommended that people at low risk, which in other words, that don't have a family history of colon cancer, start getting screened with colonoscopy beginning at the age 50 and then every 10 years thereafter. Okay,
now if they had some type of history in the family of colon cancer or polyps maybe, should they consider being screened earlier? If so, around what age?
Around age 40 is what is recommended if you have a family history. And then there are certain individuals that have a genetic predisposition to colon cancer. This is called hereditary non-polyposis colon cancer syndrome. Okay. And it's a genetic disease, and these people can get colon cancer at a very early age. I saw a patient in their 20s with colon cancer. Oh, so it's currently recommended if you have a history that's suggestive of that, you start getting screened at least 10 to 15 years earlier than your relative that had the colon cancer. So that if your relative that had the colon cancer was in their 30s, then you should be screened in your 20s. Okay. Now with colon cancer, we will get into Crohn's disease here. Just one other question with that, because sometimes people think if you find it, I'm going to die anyway. That's not true.
Explain that, yeah.
Colon cancer has a very high cure rate, particularly if it's picked up very early. And we stage the colon cancer when we find it. But if you look at survival rates or cure rates for colon cancer, and we talk about 5-year survival rates, they're 50% or greater for all comers. But if you pick it up at an early stage, the survival rates are about 80%. But we don't want to find colon cancer on patients. We want to prevent colon cancer. And one of the techniques we use to prevent colon cancer is by removing small polyps of the colon. These are precancerous tumors of the colon, and studies have shown that you can prevent 90% of colon cancers by removing these polyps. So part of the process of doing colonoscopy is to look for these polyps as well as cancer and remove these polyps. And that's very important in terms of prevention. Okay, and once again, another reason that we should have our colonoscopies as we are being advised by our physicians at the appropriate times, because it can pick up those precancerous polyps that can be removed and you're fine. Absolutely. Okay, let's look at Crohn's disease. Now, what exactly is Crohn's disease? Well, Crohn's disease is an inflammation of your intestinal tract, and it can start anywhere from the mouth to the anus, but most commonly it affects the large bowel and the small intestine. Okay. And patients present usually with symptoms of abdominal pain, bleeding, or diarrhea, and it really depends on the part of the intestinal tract that's affected. It causes ulceration and inflammation of the intestinal tract. If it attacks the small bowel, generally this can cause either bleeding, diarrhea, or sometimes blockage of the bowel, because as it inflames the bowel gets more narrow and can cause an obstruction of that bowel. So they may present with abdominal pain and distension of their abdomen and have a small bowel obstruction.
Okay.
If it affects the colon, it almost always presents with diarrhea or bloody diarrhea, and not usually with obstruction.
Okay, we're going to talk about those a little more specifically. Let me back up and ask this one question in relation to Crohn's disease then, because you talked about what it affects. Is it a virus? Is it a bacteria? I mean, we're all really conscious sometimes of how do we catch it? How do we get it?
Well, that's an excellent question. There have been multiple theories of what causes Crohn's disease, including an infectious process. There have been theories that mycobacteria, similar to tuberculosis, can cause it. But at this point, we don't know what causes it, and we do not think it's an infectious agent, so you can't catch it. What we think it's is an immune system phenomena. In other words, certain individuals get exposed to the same type of pathogens, the bacteria and viruses we all do, but their immune system reacts differently. And they often react differently to the normal intestinal flora, and it gets hyped up or hyperimmune, so that something where we might have a virus or something like that, will remove the virus and will have normal function. The person with Crohn's disease has a genetic predisposition towards getting a hyperimmune response, so that even though you clear the virus or the bacteria, your intestine continues to cause this inflammation, because the way we get rid of viruses and bacteria is by causing an inflammatory response.
Okay.
And now in these Crohn's disease patients, it goes way beyond any response to a virus or a bacteria, and it causes increased inflammation in the intestinal tract. And that's what causes the disease. So it's one of the groups of autoimmune disease that we see, such as rheumatoid arthritis and lupus, in which the body's immune system is abnormal.
So like you're saying, with this hyper response, just sort of in layman's term, the body just, as you said, overreacts. It just takes it too far.
Absolutely, and almost attacks itself, you could think of it as that. Like in rheumatoid arthritis, the body attacks the joints. In Crohn's disease, the body sort of attacks the intestinal tract. And that's important because the way we try to treat this is to modulate the immune response and decrease the amount of immune response that the body has.
Okay, we're going to get to that more specifically too. You did mention about genetics. Tell us a little bit more about that. If you have someone in your family who's had Crohn's disease, some people want to know, are you going to get it? Or are you just more likely to get it?
You're more likely, that's correct. It is not like brown eyes or blue eyes where there's one gene that transmits the inherited disorder. There is probably a bunch of different genes that get turned on and turned off during the process of this. But there is a predisposition. If it runs in your family, you're more likely to have either ulcerative colitis or Crohn's disease, but specifically Crohn's disease. Okay,
well, we're going to take a really quick break, and I want to come back and talk more about this, the genetic component, and look at ways in which we might be able to prevent, if that's a possibility, and then we'll get back to the causes and more detail about treatment and the hope that always is at the end. So you stay put?
Yes.
And you stay put. We'll be right back.